Hello everyone, good afternoon. So in last class we discussed about pulse. Today we will discuss about the jugular venous pressure. So as we know that our heart can be divided into two compartments, that is right and the left. Okay, so right is mostly designated for the venous system, and the left side of the heart is mostly the arterial system. So we receive the deoxygenated blood from the systemic circulation via the inferior and superior vena cava to the right atrium, then it goes to right ventricle, and from the right ventricle through the pulmonary trunk it goes to the pulmonary circulation, and then again it backs to the left side of heart, and from there it is pumped to the different part of the body. So this arterial pulse examination we have seen in the last class. Mostly with the examination of arterial pulse we see the activities or function of the left side of the heart. So as we see the left side of the function of the left side of the heart by examining the peripheral pulse, so the same way we can have some idea of the functioning of the right side of the heart by examination of venous system, and most commonly the vein that is examined to assess the function of the right side of the heart is internal jugular vein. So that's why today's topic is on internal or jugular venous pressure. So the jugular venous pulse, we have already discussed that jugular vein provides the information related to the dynamics of the right side of the heart, and the arterial pulse and systemic blood pressure reflect the dynamics of the left side of the heart. So if a person is having the failure of the left side, or we say that the left ventricular failure, then you will get the low BP or this low volume pulse. But remember one thing, this though it is compartmentalized, we divide the heart or compartment wise like the right and left, but ultimately if one side of the heart is affected, after some time it will affect the opposite side of the heart. So the jugular venous pulse, you have to understand it has two components. One is the pressure component, another way is the waveform. So the pressure, internal jugular venous pressure, that is degree of distension. When we examine for the jugular venous pulse, we see the distension, and this distension of the how much it is distended and the height of the distension, it directly reflect the pressure of the right atrium. As we can see from here, this from the right atrium, the superior vena cava, and from the superior vena cava it goes like the internal jugular vein. So it is lie on the same plane, and this vein is valveless. So any change in the right side of the heart, or especially the right atrium, it directly reflected into the internal jugular vein. Then comes the waveform. We know that the atria sometimes relaxed, it having the diastole, sometimes having the systole. So depending upon the contraction of the right atrium, it developed or it produces some waveforms, and these waveforms, like we have discussed in the arterial pulse, and this is this traveling wave that we perceive in the peripheral artery, that is actually the arterial pulse. So here also the same things, the change in the change at the root of the left atrium, or inside the left atrium due to subsequent systole and diastole of the left atrium, it produces waves, and these waves are traveling to the different venous systems. And as we know that the internal jugular vein is the nearest vein or the nearest branch that is very near to the right atrium, that can be assessed from exterior. So we got some wave form or waves in the jugular vein, and it provides the information about the function of the right side of the heart. So, and this is all possible as we discussed because of the lack of the valves between the right atrium and internal jugular vein. So this is the reason why we examine the internal jugular vein, not the external jugular vein, because the external jugular veins, they may have valves, and any change in the right atrium may not be reflected properly in the external jugular vein. So which jugular vein to examine, internal or external? So internal jugular vein is preferred over the external jugular vein because it is a direct continuation of the right atrium, hence reflect more accurately the dynamics of the right heart. Predominantly prominent valves in the proximal external jugular veins, it prevents the direct reflection of the right atrium into the external jugular veins. That's why we avoid examining external jugular vein. And also the external jugular veins is superficial, that may pierce the fossa. We have the deep cervical fossa and external jugular veins that pierce the deep fossa. So if you move the neck in the sideway or try to flex or extend, or you just try to make the superficial muscles taut, so it may affect the flow in the external jugular vein. So that's why we better to examine the internal jugular vein. But remember one thing, if external jugular vein is easy to visualize and if it is pulsatile, then it is more easy to examine than the internal jugular vein. So if you get a pulsating external jugular vein, that means there may not be enough valves, or it may reflect the direct continuation of the external jugular veins to the right atriums, and this particular situation we can examine the external jugular vein. So the pressure and the waveform, two things we examine in the jugular venous pulse. And the pressure, what we examine is the pressure of the right atrium that is reflected to the venous system, and that is measured by the height of the pulsation, that we will discuss subsequently. We will see how we will examine. Then the waveform, the pulsation of the external jugular veins, that gives you idea about the activity of the right side of the cardiac chamber. So how to examine? The first step is if the patient is in sitting position, chin slightly elevated and rotate to the left side. Look for any pulsation in the neck between the two head of the sternocleidomastoid. So if you move like this, your head, then you will get easily the two heads of the sternocleidomastoid. One is the sternal head, and another one is clavicular head. Or in the upper part of the neck, medial to the sternocleidomastoid muscles. So medial to the sternocleidomastoid muscles. Try to notice any pulsation and confirm it, whether it is jugular venous pulsation or the carotid pulsation. Understand? So if you get a pulsation here in the neck region, medial to the sternocleidomastoid muscles or between the two heads of the sternocleidomastoid, then try to differentiate it, whether it is actually jugular venous pulsation or carotid pulsation. And if you do not get any pulsation, then we will go to the step second. Make the patients to lie comfortably with the trunk inclined at 45 degrees to the bed at waist, with chin slightly elevated and rotated to the left. Look for any pulsation in the neck between the two heads of the sternocleidomastoid muscles, or in the upper part of the neck medial to the sternocleidomastoid muscle. If you notice any pulsation, confirm it, whether it is jugular venous pulsation or carotid pulsation. If there is any pulsation, then you go to the step 3. So decrease the angle of the inclination below 45 degree. You can see from this image. So if on 45 degree also, if you are not getting any pulsation, that means you must be sure that jugular venous pulsation is not high, is normal only. So but still you have to look for the pulsation. Though the pressure is normal, you have decreased the inclination below 30 degree, then you will start seeing the pulsation over the clavicle or above the clavicles. Then you measure the vertical height. You can see here how the height is measured. Okay, here you can see From the external angle, we measure the vertical height. So suppose here there is a pointer that shows that this is the place where you get the pulsations, and the vertical distance from the external angle is around 5 centimeters. So this is the vertical distance from the external angle is 5 centimeters. Then you have to add plus 4. We will see later on. But before that, if you get a pulsation, then you have to differentiate with whether this carotid or the jugular venous pulsation. So any pulsation in the neck, yes. If yes, then you have to decide whether it is jugular venous pulsation or carotid pulsation. So differentiation, how we will differentiate between the jugular venous pulsation and carotid pulsation? The jugular venous pulsation are superficial and lie along the sternocleidomastoid muscles. Okay, and it has a typical undulating, having multiple peaks and trough like this. It goes like this. But in carotid pulsation, it is a single upstroke. It is lateral ward movement, and it is more medial in the neck, situated lateral border of the larynx and the trachea, just lateral to the larynx and the trachea. Okay, and they have a single upstroke, single movement. Here, this jugular venous pulsation is undulating. Then, jugular venous pressure, it descends. The descent is more. The inward movement is more prominent than the upstroke, the crest. But in carotid pulsation, the upstroke seen outward movement as outward movement is more prominent than the descent. Jugular venous pulsation, a definite upper level may be appreciated. You get a definite upper level. So on the basis of that only we measure the vertical height. But in carotid pulsation you will not get a definite upper level. Then jugular venous pulsation, if you try to touch that, you will not able to feel it. That's why it is said that it is better seen than felt. But in carotid pulsation, it is better felt than seen. So you can better palpate the carotid pulsation. If you get a pulsation, the most likely it is carotid. But in jugular venous pulsation, you will not able to palpate it. Then again, the height of the pulsation in case of jugular venous pulsation varies with the patient position and respiration. So during inspiration, it will go down. During expiration, it will go up. So if your patient makes them to lie, then you can able to see the pulsation. And if you ask him to sit down, then it may go vanish it. But carotid pulsation, it is independent of the patient position and respiration. Then again, the pulsation obliterated by pressure over the root of the neck like this. Over the clavicle, you put your fingers and press it slightly, gently. It will obliterate the pulsation if it is due to jugular venous pressure. But pulsation of the carotid pulse artery, you won't be able to obliterate over the root of the neck with gentle pressure. Or you have to apply you have to apply very much force to obliterate it, but it is much easier in case of jugular venous pulsation. Then the height of the pulsation varies with the pressure over the abdomen. That is called the abdomino-jugular reflex. But there in carotid pulsation, it is independent of pressure over the abdomen. So if you press over the abdomen, it should basically written as abdomino-jugular, sometimes hepatojugular. So, but we do not press over the liver, but over the center of the abdomen. So again, just revise. Jugular venous pulsation, superficial and lie along the sternocleidomastoid muscles. It is undulating, having multiple peaks and troughs. Descents are more prominent than the upstrokes. A definite upper level will be appreciated. It is better seen than felt. Height of pulsation varies with the patient position and the phase of respiration. Pulsation can be obliterated by gentle pressure over the root of the neck like this. Then the height of pulsation varies with the pressure over the abdomen. But in the carotid pulsation, it is more medial in the neck, situated just lateral to the trachea or the larynx. It has a single upstroke, that is outward movement. Upstroke seen as an outward movement is more prominent than the descent. There is no definite upper level. It is better felt than seen. It is independent of the patient position and respiration. Pulsation may not be obliterated by pressure over the root of the neck, and putting pressure over the abdomen, it will not cause any change in the arterial pressure. Now, how we do the hepatojugular reflex is also called as abdominal jugular reflex. For the abdominal jugular reflex, at the present 45-degree inclination, when the jugular venous pulsation is not visible, press the center of the abdomen for 10 seconds or more. A positive jugular reflex, abdominal jugular reflex, will be manifest as increase in the jugular venous pressure, followed by a rapid drop in the pressure of more than 40 centimeter on the release of the abdomen. So when you press over the abdomen, it will increase the height of the pulsation, and when you will release, it again fall down. So if that fall down is more than 4 centimeter, then we call it as positive hepatojugular or abdominal jugular reflex. So measuring the jugular venous pressure. For the measuring, you can see from this image, you must have one scale, and that scale kept vertically over the angle of the sternum, or called mandibular-sternal angle. Then we have to assess the topmost level of the jugular pulsation, and when we got this topmost level of the jugular venous pressure, then horizontal line we have to make here with the help of this straight, we can see. Then we have to measure the vertical height of the jugular venous pulsation. So whenever you got a visible jugular venous pressure, you have to measure the vertical distance between the sternal angle and the topmost level of the jugular venous pulsation. Normal right atrial pressure is 9 centimeter of the water. Okay, so the distance between the sternal angle and the center of the atrium is around 5 centimeter. So outside, above this sternal angle, 4 centimeter left, if you consider the normal range, and that 4 centimeter lie usually, the vertical distance comes as at the level of the clavicle. So as the distance between the sternal angle and the right atrium is 5 centimeter, normally the jugular venous pulsation do not exceed 4 centimeter above the sternal angle, and thus not visible in sitting position. Okay, so an increase in the jugular venous pressure above the sternal angle of more than 4 centimeter suggests increase in the right atrial pressure, except a person having superior vena cava obstruction, which can cause non-pulsatile distension of jugular venous pressure. So if the height of the jugular venous pulsation is more than 4 centimeter above the sternal angle, that means the patient is having a jugular venous high arterial, right atrial pressure. But remember one thing, even if the patient do not have the high right atrial pressure, but still you can get the distended neck vein if there is any obstruction. So variation in the jugular venous pressure and Kussmaul sign. So normally what happens, the jugular venous pressure falls during inspiration due to more negative intrathoracic pressure, facilitating more blood return to the right side of the heart, and that goes through the pulmonary circulation. But in case of constrictive pericarditis and some cases of cardiac tamponades, this increase in venous return to the right side of the heart is not accommodated properly, because heart is not able to distend properly because of the constrictive pericarditis or pressure from outside due to cardiac tamponades. So what will happen? It will not accommodate properly, as ventricle is not able to dilate during the diastole properly. As a result, there is a paradoxical elevation of the jugular venous pressure during inspiration in case of constrictive pericarditis and cardiac tamponade. That is called Kussmaul sign. So again I am repeating, during inspiration jugular venous pressure falls down, but due to cardiac tamponades and constrictive pericarditis, as ventricle will not able to expand to accommodate the extra inflow of the blood, it will be reflux back to the venous system and reflected as increase in the height of jugular venous pressure during inspiration. In case of cardiac tamponades and constrictive pericarditis, we call it as Kussmaul sign. Now coming to the causes of the jugular venous pressure. The first is the congestive cardiac failure. This is very common. Okay, then core pulmonary, constrictive pericarditis, cardiac tamponades, hypertrophic or restrictive cardiomyopathy, pulmonary embolism. It is an acute causes of increased jugular venous pressure. Then the right ventricular infarct, tricuspid stenosis, volume overload, and of course the superior vena cava obstruction. Remember, in superior vena cava obstruction, there will be elevated pressure, but it will be non-pulsatile. Jugular vein is distended, but non-pulsatile distension of the jugular vein will be there. So, we have to understand a little bit about how the different pressures waves are generated in jugular venous pulsation. So, in sinus rhythm, jugular venous pulsations having two prominent waves, that is A wave and V wave, and that are separated by two descents, namely the X descent and the Y descent. So you can imagine this is the image. Where is the A descent? A wave, V wave. Then A wave is followed by the small C wave. We will discuss what is C wave later on. Then Y descent, X descent, then the Y descent. Okay. So if you try to collaborate with the ECG, then you can see that now QRS complex coincide with the A wave, then the P wave goes before that, the X descent corresponds to the T wave, like that. So, for the examination of waveforms in the jugular venous pressure, always simultaneously check the heart sound and the carotid pulsation and the jugular venous pulsation. The positive wave that seen synchronous with the first heart sound is A wave. Remember these things. So you can see this now, sound also written as S1, S2. So the positive wave that synchronized with the first heart sound is the A wave. So don't confuse, do not predict by yourself that this is A wave and this is V wave. So once you identify the A wave, then it becomes easy to identify the V wave. So any wave that comes between the subsequent first heart sound is the V wave, and it usually comes around the second heart sound. So the pulsation, the positive wave seen synchronous with the first heart sound is the A wave, and the positive wave that seen around the second heart sound is the V wave. The descent that comes after A wave is X descent, and the descent comes after V wave is Y descent. Okay. Now, coming to the normal waveforms of the jugular venous pulses, the A wave. This is the most prominent positive wave in the jugular venous pulsation pulse tracing. You can see the height. A is always bigger than the V, and it is produced by the atrial systole that leads to retrograde flow into the superior vena cava. It precedes the upstroke of the carotid pulse and almost comes at the same time with the S1. It follows the P wave of the ECG. C wave, a small interruption on the X descent. So basically after A wave there is a descent, X descent. So there is a small interruption in the X descent that is called the C wave. And it is suggested to be produced by bulging of the closed tricuspid valve into the right atrium at the beginning of the right ventricular systole. Or many people they say that it is the reflection of the adjacent carotid wave, carotid pulse, that is perceived as the C wave. Then the X descent. At the end of the atrial systole, what happens? The pressure fall in the atrium due to atrial diastole, and also tricuspid valve descends during the ventricular systole, and this gives rise to X descent. And this is the most prominent motion in normal JVP. So as already we discussed, the descent is better seen in the jugular venous pressure. So this is the most prominent motion while examination of the JVP. Okay, that is the X descent. Then the V. What happens during the ventricular systole with the closed tricuspid valves? As the blood is coming back to the right atrium, there is a passive filling of the right atrium. Continue. And this passive filling of the right atrium during the ventricular systole with the closed AV valve increase the arterial pressure that gives rise to V wave. So it is during the ventricular systole. So we get the V wave during ventricular systole at the beginning of the ventricular systole. So that's why it is ventricular systole. That's why we get it synchronized with the S2. Then at the end of the ventricular systole, when the ventricular diastole starts, the tricuspid valves open. So if it opens, it allows the atrial blood to go inside the ventricle. So there is a drop of the pressure in the right atrium, and this drop of the pressure in the right atrium ultimately gives rise to Y descent, and this is a downslope of the V wave. It is also called diastolic collapse, and it begins and ends during the diastole. So you can see the S1 and S2, the area between S1 and S2 is the ventricular systole. So we will get C wave, X descent, and the upstroke of the V wave. From the upstroke of the V wave to the second A wave, this falls between the S2 and S1, means diastole. So the Y descent is the diastolic phenomenon. So coming to some basic abnormalities of the A wave. So A wave, we know this is the most prominent positive wave in the jugular venous pulsation, and A wave is produced by the atrial systole. So if you think a condition where there is no atrial systole, atria is not able to contract effectively or in a synchronous manner, for example in case of atrial fibrillation, then there will be no effective atrial systole that gives rise to absent A wave, we call it as atrial fibrillatory wave, where we'll get the condition is atrial fibrillation. Then the giant A wave. For example, when the right atria contract against some stenotic tricuspid, or there is some obstruction in the outflow of the atria, right atria will contract, but the blood will not go into the ventricle because of properly, because maybe of ventricular hypertrophy, or the pathway may be narrowed because of the tricuspid stenosis, or there may be pulmonary stenosis or right ventricular hypertrophy or pulmonary hypertension. The further flow from the ventricle to the pulmonary circulation. So in these conditions, what we get? We get a giant A wave. Okay. So here atria is contracting against high pressure area. Just imagine one thing. Atria is contracting, ventricle is contracting, and if both contract at the same time due to some complete heart block or some dysynchrony between the atria and the ventricle. So when the atria contract again a closed tricuspid valve, then what will happen? Atria will not able to eject the blood into the ventricle, and all blood will be go back to the systemic venous system. And these conditions we will get typically cannon A wave. Okay, cannon like things. No? So when atria contract again closed tricuspid valves, as in case of complete heart block or ventricular ectopic or VT, when sometimes both atria and ventricle contract at the same times, we will get cannon A wave. Now giant B wave, or sometimes it is also called as CB wave. What happens? After A wave we get a small interruption, that is C wave, then X descent. For some reason, if there is no X descent and A wave continue as positive wave up to V wave, then we call it as CB wave. And when we get it, we know that X descent happens during the ventricular systole. But just imagine if this AV valve is not competent, or this incompetence, there will be regurgitation of the blood from the ventricle to the atria during the ventricular systole, and that will come to the right atrium and then will be reflected to the venous system. So we get giant V wave typically in case of tricuspid regurgitation. Then the prominent X and Y descent and prominent Y descent. We get typically in case of constrictive pericarditis both prominent X and Y descent, and prominent X descent we get in cardiac tamponade. So just we will revise again: the absent A wave, atrial fibrillation; giant A wave, atria contracts against the stenotic tricuspid valve or non-compliant hypertrophic right ventricles like right ventricular hypertrophy, pulmonary stenosis, or pulmonary arterial hypertension. Then canon A wave we get in complete heart block, cause atria contract against the closed tricuspid valve. Giant V wave we get in tricuspid regurgitation, prominent X and Y descent in case of constrictive pericarditis, and prominent X descent in case of cardiac tamponades. So with this we comes to the end of the jugular venous pulsation. Thank you to all for attending the class.
Yes, sir.